Hi, everyone. Welcome to our virtual pathology interest group journal club. My name is Claire. I'm one of the event coordinators, and this is Taya, our lovely president. And I just popped a survey link in the chat if you guys want to take a moment to fill it out when you get the chance. And I'm going to start sharing my screen. Hopefully, you saw the article beforehand. If not, that's totally okay. All right. Can everybody see my screen?
Yep.
Okay. So the study we're talking about today is evolving TRALI risk across apheresis and whole blood platelet products in the United States. It's an 18-year American cross hemovigilance analysis. Those are the authors of the study. All of the interpretations of this article are mine. This is not sponsored by the authors at all. They are not involved. So anything that's overinterpreted or underinterpreted is 100% on me and not on them at all. Oh, come on. I want to advance. So go. There we go. Okay. So first, let's talk about what is TRALI. It's transfusion-related acute lung injury, and we kind of think about it as kind of a two-hit hypothesis where the donor antibodies activate primed neutrophils and pulmonary endothelium in a primed recipient. So these are people who we are concerned about. They're usually very critically ill or have an underlying lung pathology or are septic, and so their body is already primed to kind of react. And donor antibodies that we're kind of worried about are HLA and HNA antibodies, which will bind to the neutrophils and the pulmonary endothelium and cause a non-cardiogenic pulmonary edema. This is fatal in about 10% of reported cases, and treatment is largely supportive, so the focus is very much on preventing this in the first place. And so when we think about blood components that we're concerned about, we think primarily about like platelets and plasma. And there are lots of different platelet preparations. So one of the preparations we're going to be talking about the most and the most concerned with is pooled whole blood platelets, where platelets are derived from multiple units of whole blood to create one unit of platelets. And then platelets derived from plasmapheresis, which also include pathogen-reduced platelets, platelet additive solution platelets, and the combined platelet pathogen-reduced and platelet additive solution platelets. And the other ones we think about are plasma and whole blood and red blood cells. So, like I said, we have to think about reducing the risk of TRALI. And as we think about this, we're going to think about, okay, donor risk reduction strategies and recipient reduction strategies. So we can't really reduce the recipient risk strategies because the thing that makes this recipients kind of prime towards TRALI are probably the things that's causing them to need a transfusion in the first place. So we can't really say like, ooh, be less sick. So we have to really focus on the donors. And so when we think about the donors, we want to think about people who are at increased risk of having a lot of antibodies in their blood circulating towards antigens that aren't self-antigens. So there are two primary populations we really worry about having a lot of extra antibodies. And these are people who have gotten a lot of transfusion in the past. So people who have thalassemias or sickle cell and require transfusions periodically, or are pregnant patients. Because when you're pregnant, or if you've had multiple pregnancies, especially, your body creates a lot of antibodies against baby's blood that might not look exactly like yours. The classic one we think about is an Rh positive baby and an Rh negative mom. But this happens for a lot of different antibodies and antigen targets in the baby and mom. And so women who have been pregnant aren't the best blood donors because there are increased levels of a bunch of antibodies that we have to kind of think about. So currently we reduce the risk of TRALI by preferencing male donors and women who have never been pregnant, or if they have been pregnant, have tested negative for the certain antibodies that we're worried about in TRALI. So this article specifically is addressing what is the current risk of TRALI for different platelet preparations? What is the current risk for whole blood components? What contribution of the donor mitigation strategies and manufacturing changes in the reduction of TRALI risk over time? And then what high-risk situations still remain that can be targeted for further intervention? So how the paper looked at the study is that they used the American Red Cross Hemovigilant database, which is a database that basically catalogs every single transfusion reaction that's reported. That's kind of the big caveat with all databases. And they only included cases with a single component type used. So they focused on cases where we only had maybe like pathogen reduced platelets or only had plasma, or only had pool hold platelets but did not mix components. So they weren't going to consider cases where TRALI was reported, but somebody got maybe red blood cells and platelets separately. So we're not going to think about those. And then these cases also had to meet the P5 and P6 case designation criteria, which is basically a high suspicion of TRALI with either a donor kind of risk factor known, or it's probably TRALI, but the donor risk factors weren't really identified. So either the donor didn't have one of the high risk features that we screen for, like past transfusions or past pregnancies, and we didn't identify an antibody in the blood. Doesn't mean it wasn't there, just means it wasn't identified. And then they calculated trolley risk as incidence per million types of units distributed. And they separated the data into two pools from 2006 to 2016 and from 2017 to 2023 to reflect the spreading use of PAS and donor mitigation strategies for platelets. So what they found is that over this time period, 339 cases met criteria. They kind of separated out the cases from 2006 as sort of a pre-case baseline. So rates of TRALI from plasma fell sharply from 2006 to 2008 and kind of continued to drop off from there. Pooled platelets carried the greatest risk of all platelet components type when they kind of normalized across the different types. However, pooled platelets have been kind of pulled from manufacturing, and we don't really do that anymore since 2020. And then they predicted that 9 to 13 fewer incidents of TRALI in apheresis paired platelets versus these pooled platelets. So they estimated a pretty significant increased risk for using these pooled platelets. And that makes sense because if we use apheresis prepared platelets, we're pulling from one person versus if we do pooled platelets, we're pulling platelets out of multiple different units. And so there's kind of like maybe 5 or 6 people's platelets being mixed into one bag. I'm not sure the exact numbers, but it's definitely more people in one bag. And then after 2017, with the introduction of donor mitigation strategies, specifically kind of the antibody testing of women who have been pregnant, there was no significant difference in events between plasma, PAS, and pa the PAS PR platelet preparations. So this is kind of their figures. So this is the first figure, which is basically just showing kind of the number of units over time. They didn't really touch too much on red blood cells, so we didn't really talk about it in our overview. Um, And then these are kind of the two pools. And you can see plasma platelets dropped from 63 events all the way down to 4, and they've kind of been there ever since. And then these are pooled platelets. There's not a lot of these units go out. And then, like I said, none went out after 2020. So this is kind of only one event. Um, and then once again, they didn't really touch on red blood cells. So I'm not quite sure what these numbers mean in relation to the others. And then the next kind of figure they had was kind of the relative risks of each type. And so basically they compared all the different preparations to pooled platelets. And this is where they got the 9 to 13 less incidences of TRALI for other platelet preparations compared to pooled platelet preparations. So basically, what the first column is showing us is that there is a reduction pretty much for everything. So despite what we saw with the red blood cells, I guess it's still technically less events are likely than in our pooled platelets. And then they were kind of thinking about, okay, so in these people who have had TRALI, and we looked at these pooled platelet bags, how many of the donors to these pooled platelets had sort of a risk factor that we were worried about? And so this is where so I guess 5. So how many donors had kind of a TRALI risk that we knew about already? Most had 0 donors that were at risk of kind of having those being those high risk donors. And then, but some pools had all 5 donors kind of at risk. So that was less than 0.1% of these pooled platelets that went out. And once again, we're not really using pooled platelets there anymore. That's kind of been completely stopped in the United States since 2020. So the limitations of this study is that and these are their reported limitations, is that they only used one database, but I would say that the American Red Cross Hemovigilance database is probably a good single database to use since it does kind of encompass the entire United States. The bigger limitation is probably the hospital reporting of events. So if TRALI wasn't really recognized, or maybe the hospital just doesn't report these things to the Red Cross, or maybe is really busy and something slips through the cracks. So they recognize there's probably an underreporting of TRALI. And then they also recognize that there was excluding the multi-component reactions was probably also a limitation of their study. But I do think that it made it a more elegant study because then it gets confusing as to know which component was implicated in the TRALI. And then a bigger thing is the unknown patient population. So they don't know the demographics or the makeup of the patients who experienced TRALI and if there were other risk factors kind of at play. And then they also don't know the rigor of the hospital surveillance of transfusion events. So kind of going in with the hospital reporting of events, we can't really look in at the hospitals and see what was happening. So some discussion points that I thought we could talk about tonight is should the US adopt donor mitigation strategies for all blood products, including red blood cells and whole blood donation, and what are the possible implications of this? What information about the patients could be useful in determining TRALI risk, and how might this affect the results of the study? And should the US consider using platelets derived from whole blood with the potential adoption of the Revios, I probably said that wrong, system? So this is something that's newer to the market, and they touched on it briefly in the discussion of their article. It basically can spin down whole units and into their component parts. So the red blood cells, the plasma, and the platelets. And there is some talk that maybe this would bring back pooled platelets because this could automatically spin down. And but then we get back into the pooled platelets are one of the riskier platelet components to use and increase TRALI risk. So should we consider using platelets derived or should we kind of throw that part to the side? So now I want to open it up for discussion. I can also drop the article in the chat if you guys need it. I know it's a very small group, so we don't really have to do breakout rooms or anything. I'm going to stop my screen share. Or maybe I won't so that we can see the discussion points. And also any other questions if you want me to go back to something and explain something.
Yeah, I guess I can start with the first bullet point, and then I do have one follow-up question to go to. In terms of increasing donor mitigation strategies for all blood products, I think the one thing to think about there is then are we decreasing our donor pool without having enough evidence to do so? And if we are making these kind of like large scale restrictions, I would kind of want to make sure that it is completely evidence-based and we're not taking away donors that we could otherwise use without the need. So I wonder, Claire, if you kind of have any notions about that or what the best kind of recommendations you would have after reading this article or maybe from your own knowledge base.
Yeah. So that was also kind of my first thought because they posit that too in their article, like, oh, maybe we should use these donor mitigation strategies for everything. And I do think it's kind of important to think about. However, there's some data that suggests that women make up more of the donor pool than men, or women are more likely to donate blood on a regular basis than men are. So that could definitely pose a big barrier. So that's one thing to consider. And I think another thing, though, is that we can test the blood components for antibodies. And so we can kind of pull out from there. That could be very useful. And that would be a donor mitigation strategy. And I would say, I think a thing that we kind of need to be better about in general is very much encouraging young men to donate, especially young men. I was talking to a blood banker and we were talking about all the different types of blood donation components. Oh, someone entered. So we're talking about all the different like blood donation types and especially like peripheral stem cell donation for bone marrow transplants. And kind of in all these situations where like blood donation, you want someone who is larger. That's kind of the ideal versus someone who's smaller. And you do want people who don't have as many antigens. So maybe a strategy would be kind of like as silly as it sounds, going to colleges and getting fraternities to do like blood drive competitions with each other and to kind of either donate a lot of blood components or maybe get some better like stem cell kind of reserves going and like see if they can be a match, things like that. So I think if we kind of go with the donor mitigation strategy, we should also be a lot more aggressive about kind of recruiting donors.
Yeah, I think that definitely makes a lot of sense, making that balance out a little bit.
Yeah. So.
And then the other question that I had, and then maybe we can move to the second bullet point. Can you speak a little bit more about the table where they were calculating the trolley risk, where it was all like five donors had a trolley risk and kind of talk, yes, this one, and kind of talk a little bit more about how that like risk was calculated. I'm
Yes.
curious.
So basically, kind of like we're talking about, and maybe I didn't really explain it very well, with whole blood derived platelets, you take a unit of whole blood and you spit it out into its parts, and then you take the platelets off. And to make a whole unit of platelets, you need platelets from multiple different bags, essentially, of whole blood. So that's multiple different people. So when you donate blood, which I will admit I have never done, I was specifically told by a phlebotomist to never do that because my veins are too hard to stick. So I listened. Um, you have to fill out a health questionnaire though, and one of the things they ask is basically, have you ever been pregnant and have you ever received a transfusion before? And that's the question they're asking to kind of get after donor risk. Because they can already see like the male female when you create the form, and then the other thing is this is like the specific one. So in the article, when they're talking about trying to figure out donors with the risk factor, they just looked at that specific question to see did they say yes or did they say no? So this is completely based on the donor health questionnaire and not any back testing for to see if they had an antibody or any donor testing that was done. So this is the breakout of how many kind of donors into a pool platelet had a risk factor. Does that make more sense?
Yeah, yeah, no, that definitely makes sense. Just comparing it to the restrictions that were then put in place.
Advance the slides.
I thank you for hosting this. My name's Alex. I'm an M1 medical student, and
Welcome.
I just wanted to get some clarification on because this is all kind of new to me, these
Mhm.
pooled platelets. So if I just want to get clarification and seeing if I'm understanding this right. So you have a bunch of people donating blood, and some individuals may confer like a higher trolley risk. So the idea is that having pulling them together might not give you like an accurate view of, or it can make it difficult to predict who will who will have get trolley.
Kind of. So with the pooled platelets, so you're right that we have the whole blood and how we used to process before we kind of have apheresis and now they can selectively pull off a certain type of blood component, is we used to donate whole blood and then spit it out into its components. And with our pooled platelets, we just have multiple different people kind of going into one bag essentially because we need platelets from a lot of different people. So I'm not sure I'm getting at your question necessarily, but the pooled platelets don't really have much to do with the recipient risk factors, um, beyond the fact that like the pooled platelets just are like more likely to have maybe a donor who is gonna be have one of those risk factors for having the antibodies. And it's really like the presence of those antibodies on the donor side that we're super worried about. If we could like test units before we sent them out, that'd be one thing. But platelets are really hard units to store. That's kind of the big issue with platelets, is they have a very short shelf life compared to the other blood components, even when they're frozen. Um, so they're very difficult for health systems to keep on hand. I'm part of a big health system for my training, and we do keep plasma or platelets components just at all the hospitals. And I know that there's like a courier system where on like day whatever, they bring all the platelets to the central location where we're way more likely to use them. And they are all constantly like cycling through the platelets just because we can't stock them. So that's kind of an issue with platelets. Sorry, that was a tangent. Um, the maybe I'm trying to get at your question. Were you wondering why like they didn't look at different components kind of combined for one per that went into one person?
Yeah, just conceptually, like understanding the challenges of, actually delivering the platelets, I think sort of helps me understand the research a little more.
Yeah, so platelets are just really hard to like keep on hand. That's the big issue with platelets. If you ever shadow a blood banker, which I highly recommend, and you ask them about it, they will tell you extensively. But one of the things that the study excluded was people who had received different types of blood components. So when I don't know like what how your school does it, but at some point you'll have a lecture on the different types of blood components, and there are lots of different things you can get in the hospital. So you can get whole blood, which is really used a lot in trauma protocols or massive transfusion protocols. But a lot of times people will get components mixed together. So you get packed red blood cells, you'll get plasma, and you'll get platelets. Or maybe you'll just get plasma and red blood cells. Who knows? To each their own. Um, and so this study kind of excludes people who may have had TRALI but did receive different component types. So if I went to the hospital and I received only whole blood, I would be a candidate for the study. But if I went to the hospital and I received PAS-PR platelets, and then I also received plasma, and then I also received plaque red blood cells, I am not a candidate for this study because then we can't pinpoint which bag essentially was the TRALI bag, so to speak.
Okay, that makes sense. Thank you.
Mhm. Okay. And I guess move on to the second discussion point, is what information about the patients could be useful in determining trolley risk and how might this affect the results of the study? I'll say I had a thought in my head when I wrote this discussion point, and now I'm trying to remember what that thought was. I think part of my thought was kind of more on the hospital and less on the patient. So, what type of hospital the patient is in, I think could be important because if you're at a hospital that is very vigilant about trolley and is very familiar with it and transfuses a lot of blood components, they're going to be much more likely to catch and report this than a hospital who maybe doesn't have as much experience or isn't as familiar with blood components, with transfusion protocols. And obviously, this happens at every hospital. There's always transfusion happening somewhere, probably. But there are definitely places where they do it a lot more often. And so I thought that that might be something is that maybe hospitals who aren't as, this doesn't happen as often might underreport, essentially.
Yeah, I'm also wondering if there's any kind of state to state differences in hemovigilance, and some are compulsory and some aren't. And so there could be some difference there between where these events happened.
Yeah, that's a really good question that I do not know the answer to. That's a good one, though. All right. And then we can just kind of wrap this up. So then like the last thing is I guess just y'all's opinion, like should we consider using platelets derived from whole blood in the future if like we have this system that works really well and once again platelets are kind of hard to store, so like this could be helpful for that. Um, from I guess that was kind of my interpretation of the system, although Lord knows my interpretation is probably not the correct one. Some of this goes like way over my head, truthfully. Or and like could we, maybe there's donor mitigation strategies we could use, maybe there's other strategies we could use. So like what are the thoughts about that one?
To me, I think it's something that could make sense if we do have these technologies in place, and I kind of only see these types of things expanding. So I think it would make sense to implement and perhaps, see if we could, one healthcare system would be willing to implement it and do a kind of one site study and then move on. I think that would be like nice to start to get some preliminary data for at the healthcare system level to see if this could really improve outcomes or improve availability, of products.
I think maybe, I'm not entirely sure, but it could lead to interesting regulatory challenges. Because I'm just looking at the article now. FDA rules still demand that whole blood is processed within 8 hours, so that would have to be changed, and you know, not really sure what the consequences of that change would be. But they sort of look to other countries who have different rules, so it seems like a a big change for how we currently handle whole blood.
Absolutely, yeah. It'd definitely be interesting to see what happens, and I think, like Taya said, that kind of one site or maybe like 10 site study or something would, like, that's definitely gonna happen. Like, they're not just gonna they're not just gonna implement it. Probably, hopefully. Um, but yeah, definitely keeping an eye on that and seeing like where it goes. Because this is a very recent article. I think it was published earlier this year. So just kind of seeing where this goes in the future will be very interesting. Yeah, I think it's interesting to kind of think about going back to the pooled because know that like we don't do that too much anymore. So I always wonder if there's going to be kind of resistance because it's like, well, we know that we shouldn't. We stopped doing this for a reason. Like now you want us to go back. So I feel like that'll be an interesting thing to see if that pops up some more. But who knows? Any final thoughts or questions? Stop sharing. Oh, there's a chat. All right.
Yeah, I would just say if we could just take a quick minute just to do the survey in the chat. It should only take a minute or two. And we really appreciate it.
Yes. And please come to our events in the future, especially, if you guys are like M1s or I know you're an M1, Alex, and I don't know, Stella, if you're an M1 or an M2 or an M3, or you're an M4. There's going to be lots more events in the future, kind of geared towards introducing you guys to pathology and what the day in a life is like and some specialty spotlights. And so, yeah, just follow on social media. We're PathSig. We're pretty easy to find on Instagram, especially. And we'll have a lot more events coming your way. And then there's some recordings of previous events on the website if you weren't able to attend those.